Welcome to Season 5 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former health commissioner here in Baltimore, Maryland. Our goal with this podcast is to bring scientific evidence and experience to shed light on critical health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith-Rogers, producer of Public Health on Call. Today, Stephanie Desmond talks to Zeke Emanuel, a University of Pennsylvania health policy expert, about whether the U.S. is putting the needed resources into ensuring that people are protected from any new variant of COVID-19, studying the effects of long COVID, and getting ready for the next pandemic. Let's listen.
Zeke Emanuel, thanks so much for joining me.
It's my great pleasure. Thank you for having me.
So we're sitting here in a situation 2 years into the pandemic, and the United States state of emergency for COVID is expiring next week. And we are also seeing that there's not money in the budget to pay for things like vaccines and testing going forward. So talk to me about what the picture looks like today.
Well, I think the picture is that everyone hopes the pandemic is over and is behaving almost as if the pandemic is over. You've got the airlines wanting to get masking off airplanes and out of airports. You've got people taking their masks off, cities, states, removing their public health measures. You similarly have obviously a mood in Congress of let's move on. Let's get this behind us, where behind us also means we forget that we need to invest to sort of reduce the chances of anything bad from a future pandemic or this pandemic having another variant that's of serious concern like Delta or Omicron. So I think there's a whole lot of sentiment of move on, and you're seeing that, as you point out, in, are we going to renew the emergency declaration? You see this in, well, maybe we won't add a lot of additional resources to public health for COVID and for biosecurity and pandemic preparedness. So I think that's the present mood.
Mm-hmm. It seems short-sighted.
I think we're trying to see COVID in our rearview mirror. That's as short-sighted as you get. It's definitely short-sighted in the following two senses. First, there is going to be another variant. How bad it's going to be, how serious, whether it's going to increase hospitalizations and overwhelm hospitals and intensive care units, we don't know. I wouldn't bet against that because this virus has been very, very unpredictable. And second, we know this is not the last pandemic or biosecurity threat we're going to face. And we know that our infrastructure for facing these biosecurity threats is inadequate. And we need to spend some resources, invest some resources to boost our preparedness. And that seems to be something that there's too much resistance to, in my opinion.
Mm-hmm. So talk me through sort of what the real world implications of this are. I guess there's not yet a sum of money in the budget for COVID beyond the summer. Is that correct?
Well, I think at this very moment, the Congress is debating whether we're going to add $10 billion. And even if we added the $10 billion, there does seem to be agreement that we should have the $10 billion, but they don't seem to be able to agree to pass it because they want to attach all sorts of other contingencies that have nothing to do with this, like immigration. But even if we had that $10 billion, it's a substantially inadequate amount of money for the kind of investment we need. If you want to invest in, let me just give you a few things, next generation vaccines, whether they're mucosal vaccines, multiple variant together vaccines, invest in additional development and testing of therapeutics, invest in long COVID, large scale research projects involving hundreds of thousands of people, not thousands or tens of thousands of people. If you want to invest in improving indoor air quality, if you want to invest in surveillance of wastewater, animals, genetics, population immunity, those cost money. They're investments. I've used the word investment multiple times because they prepare an infrastructure for the future. But we don't seem to be serious about spending the kind of resources available. And let me just put it, $10 billion is $30 per American. That is not the kind of money I think most people believe we should spend on COVID and preparing for biosecurity threats.
So I know that it's harder to get a test these days, a free test these days, right? And it's, it feels like the infrastructure is all sort of breaking down as if as if we don't need it anymore. Would some of this money go to sort of keeping testing as an option and, for example, paying for booster shots if the whole population is recommended for them?
Well, I think you're 100% right. We have all these data. Cases are going down most of the country. They're going up in a few places. And all of that data is, I would say, well nigh worthless. And the reason it's worthless is precisely what you point out. Most testing is shifted to at-home testing where we get no results. And the kind of results we get are people who are really symptomatic. And so I wouldn't rely on those numbers of cases at all. We know they're missing most cases now. And we are, as you point out, shutting down all the testing sites to no avail. I am fortunate personally in that I work at a university. I can walk in and get a PCR test any time. That's very rare for Americans, and at-home tests is what we rely on, and we have no cumulative data on that. And so I think our insights into what's happening are diminishing, and we're not investing in the kind of surveillance we need. We need more wastewater surveillance, and we need better linking of the at-home test so that people actually have to download their result with a QR code and things like that.
I was going to ask you about those home tests because, every morning I go to the New York Times website and I see that we're down to very few cases, new cases. But what you're saying is that just can't be relied upon at this point because people do it at home. They never enter the medical system with this information.
Correct. So I think that is a number I would not look at. Hospitalizations is a more reliable number, but it's a lagging indicator. It follows 2 to 3 weeks behind cases. Therefore, the best data we have is in wastewater, and wastewater monitoring is very fragmented and patchy and not standardized across the country.
So many more people got insured during this state of emergency, and they were able to get, not just, obviously they got free tests and everything, but they also had access to medical care. It looks like that's not going to be the case much longer. Talk to me about that.
Well, we did substantially increase the subsidies for people in the exchanges. And that did bring out a large number of people to get insurance. We went from something like 10.4 million Americans at the low point under Trump to 14.5 million people signing up. That's a substantial increase, something like 35 to 40% increase in the exchanges, which is pretty impressive. And it shows you how much is financially related as well as information related. People, it's hard to navigate. I think, we think many of us upper middle class educated people think, it's a website, go in there, shop, ping. Even if it doesn't cost you anything, it's easy to do. But for people, many people, that's not true. And sifting through the possibilities, adding information, it's hard. And the outreach, the longer enrollment periods all have made a substantial difference and have gotten people additional coverage, in addition, making certain people eligible that weren't eligible before. The president just the other day, getting rid of the family glitch in terms of affordability. All of these small things make a difference. They're not as big as what I would like to see, which is auto enrollment. We're putting you in Medicaid, for example, and then we'll sort out where you go and what you're really eligible for. But I think that makes the extended subsidies, the extended time, the additional outreach have all made a big difference for people.
Is that running out?
Yes, Well, for example, the subsidies expire at the end of this year unless they're made permanent by Congress. Mm-hmm. Mm-hmm. And we know, the funny thing is, and I'm as guilty as every health policy expert. In the 2008 primaries, you in the audience may not remember this. There was a big conflict. The basic structure of the reform was agreed upon that we would have a sort of Massachusetts-style exchange where insurance companies would offer products, people would get subsidized to buy in the exchange. And the big conflict between Hillary Clinton, John Edwards, and Obama was that Clinton and Edwards said, listen, we're going to have a mandate, individual mandate, so people can get insurance. And Obama ran on, it's not about the mandate, it's about the subsidies. And people were making fun of him. You don't know, you're wrong. And then we put in a mandate into the legislation because us policy experts thought, you got to really mandate people, you got to force them to buy insurance, blah, blah, blah. And what's really happened is, Trump and the Republicans took the mandate away. They zeroed it out. There's no cost penalty. And then when you increase the subsidies, shockingly, millions more people buy insurance. And it does tell you, well, maybe it really is about the money. It's not really about the mandate. And, if we just increased the money and basically made insurance much, much cheaper, people would, people want it. They would buy it. So I think, in some way, it's a vindication of President Obama's position that it's about the money. It's not about the mandate. But it does tell you we probably need to make this increase in subsidies permanent if we really want to increase the number of people with health insurance.
So one of the things also missing going forward, apparently, is what's going to happen overseas. I know that the Biden administration has provided a lot of vaccines to a lot of countries around the world. And I understand there's not money for that any longer.
Yeah, well, first of all, we should disentangle things. The United, it's one of, I think, an example of where we've done a lot and gotten almost no credit for it. We've now donated over 500 million vaccine doses, and we're going to donate an additional 600 million for 1.1 billion doses. Far and away, the country with the largest donation. You wouldn't know that from everyone's response. But the bigger problem is that the world now is awash in COVID vaccines. It is not a supply problem, and it hasn't been a supply problem for months. It is a demand problem. We can produce all the vaccines we want, but that is different than getting them distributed and getting them administered to people. That's where the glitch is. So the additional funding needed would be for distribution and administration of these vaccines. But even beyond that, there is a larger problem in the world, which is this vaccine hesitancy. We have it severely in the United States, but it's also severely present in many other countries around the world, especially in sub-Saharan Africa, where people are like, I got a lot of other health problems. This COVID thing just hasn't. And let's be honest, despite all the worries, and I was among them, of the experts that COVID would be a huge threat to low-income countries, especially in sub-Saharan Africa, it hasn't. It just has not. And the fact is that they, rightly are asking a question of, well, given health priorities, given other threats that are more pressing than COVID, should we be investing in COVID vaccination versus investing in healthcare infrastructure, prenatal care, safer pregnancies, vaccines for other things, distributing malaria vaccines, et cetera, et cetera, et cetera. And I think that's a perfectly legitimate question to ask. What ought the priority be given what causes health impacts, what causes economic dislocations, et cetera, from a health standpoint? And I think kind of some skepticism about these vaccines and putting so much priority on these vaccines when there are other healthcare needs is something we have to address as a world.
One thing you did mention also was long COVID, and I wanted to sort of end on that. This is about to become it already is, a huge burden on the healthcare system. So I'm curious, folks who have had COVID and then have these illnesses that seem to be associated with it, and they're sick for a long time and they have chronic illness. This could really impact the healthcare system for a long time.
I think this is one of those issues that we have not focused sufficient attention on. We don't know exactly how prevalent long COVID is. We have known long COVID has been around since that long COVID exists, i.e., there is a persistent post-acute phase problem that begins 1 month, 2 months, depends on where you want to draw the line, after the acute illness that leaves people with significant symptoms: fatigue, shortness of breath, brain fog being the most prominent and worrisome ones to people, but insomnia and a variety of other symptoms that are very debilitating. May 2020, it was first identified. Here we are, 22, almost 23 months after, and we know almost nothing about long COVID. We don't know how common it is. There are estimates of 10% of people who get acutely infected to 30% of people. We don't know reliably whether it appears that vaccines minimize your chance of getting long COVID. We don't know how much. We don't know about treatments that might minimize it. Would Paxlovid decrease their chance of long COVID? Do steroids decrease the chance of long COVID? What other things might address this? We just don't know. This is a huge failure of the biomedical research community to do this. Now, we've launched several studies here in the United States: INSPIRE at the CDC, RECOVER at the NIH. But the sad fact is they're not moving with any urgency. This NIH has received more than $1 billion for long COVID in September. They've awarded money to sites. RECOVER is supposed to be 40,000. Now they've increased the number to 80,000 people enrolled. They haven't enrolled 2,000 people. Less than 5% of the initial estimate has been enrolled. There's no urgency. And then when we've talked to the senior leadership about, well, what clinical trials are you going to begin? When are you going to begin them? They're talking about, well, we're going to give symptomatic treatment. We know about those symptomatic treatments. They're just not that effective. Doctors have been trying them, and there's no home run there. The patients are very desperate, and they want serious interventions targeted the underlying disease. Lots of things can be tried. We don't know what the biophathophysiology is, so we're going to have to empirically, that is, just try things based upon hunches. But if you have a large number of people, you run trials quickly, you can get results pretty fast. So you could try steroids, you can try antivirals, you could try immune modulators. There are a number of things I can imagine that would be worth trying on an empirical basis. And yet, doesn't seem to be a real urgency at the NIH for doing this and for getting results out quickly. And even if there is that sense of urgency, the institutional structures seem to impair the response. And I think that's it's pretty frustrating. And I think we need an answer to that. And I think we need to get an answer much more quickly. Why do I say that? We know that if you've gotten 3 shots, vaccines, your chance of dying of COVID are really low. 1 in 30,000, maybe a little even lower than that. But that doesn't take away the risk. If you had a low chance of dying or being hospitalized or getting a severe illness, but you have a reasonably high chance of getting long COVID, you would still be cautious, or you ought to be cautious, because long COVID can really ruin your life. On the other hand, if you had a 1 in 30,000 chance of dying and a 1 in 10,000 chance of getting long COVID, it's like, well, that's kind of background risk. It's worth, just getting back to normal. And I wouldn't be excessively worried. But we don't know that number about long COVID, and we don't know what we can do to minimize the chance of getting long COVID. And we do need that information very, very rapidly, and we need to light a fire under the NIH and the CDC to get those results ASAP.
Zeke Emanuel, thank you so much for sharing your perspective.
Thank you. It's been a pleasure.
Public Health On Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Niall Owen McCusker, Matthew Martin, Spencer Greer, and Holly Cardinale, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media support from Grace Holz Fernandez. Thank you for listening.